Good morning. Welcome to our Columbia Psychiatry Grand Rounds. My name is Rebecca Muley, and I'm one of the Grand Rounds co-directors, along with Drs. Alex Harris and Adit Talati. Today is one of those achingly beautiful early days of September with blue skies and the promise of a new school year. But this day especially is one that for the past 23 years has held a still raw and poignant place in our hearts. 2 towers gone, thousands of souls perished, but their memory will always live on. A moment of silence, please, for the lives we lost on September 11th, 2001. Thank you so much. And on today especially, I am so pleased to see so many of you in the audience as a reminder that our community is what makes us strong, and having you here and with us helps to get us through each and every day. So thank you for that. We are continuing to entice you down with some coffee and pastries at 11, as well as the convivial conversation with your colleagues to start off our Grand Round series. And so we're going to continue that process. We're going to be having the speakers speak until about 12 p.m. and then have our Q&A after that. So given the shorter time frame, we're going to be limiting our Q&A to in-person. Please do still post your questions on our Zoom Q&A, and we will read them out loud in the auditorium. Next week, September 18th, will be a unique Grand Rounds. We are going to be virtually hosting the National Physician Suicide Awareness Rounds presented by the Columbia University Vagelos College of Physicians and Surgeons, Departments of Emergency Medicine and Weill Cornell Medicine, the CUIMC Office of Wellbeing, and the New York Presbyterian Cope GME. Dr. Carrie Cunningham, the section head of the Endocrine Surgery Program, Associate Professor of Surgery at Harvard Medical School, and attending surgeon at Mass General Brigham Healthcare Center, will be speaking about her experiences with a talk entitled, "It's Okay to Not Be Okay, Just Not Okay to Not Talk About It." If you register using the link in the Grand Rounds announcement, it is not our link. It will let you register with their Grand Rounds, and you can sign up to view on your own device. But we encourage you to come visit our auditorium where we will be live streaming on our big screen. And there will be a Q&A after with discussion with Dr. Lou Bautista, who graciously has offered to do some additional discussion after their series ends. They end at 12, we end at 12:30, so we're getting a little discussion in afterwards. As always, please consult the Inside website for any upcoming town halls and roundtables. Our DCM leaders will be holding a town hall this afternoon at 2 p.m., and our next town hall related to our human research protections will be held at 10 a.m. on September 24th. If you would like to contact us to meet with any of our upcoming speakers or to suggest a speaker, please write to us at grandrounds@nisbe.columbia.edu. And now, without further ado, I would like to introduce Drs. Phil Muskin and Kitty Garza to introduce the award and our speakers. They are the co-chairs of the Spiegel Award Lecture Committee.
Good morning, everybody. I'm going to talk just for a minute about Herb Spiegel. There are people in the room who knew Herb, people in the room who were trained by Herb, and I'm one of those people. When Herb was a resident at St. Elizabeth's in Washington, he made a deal with one of his professors who had been trained in Germany as a hypnotherapist, that if he would help out the professor, he would be trained in hypnosis, which is when Herb first started using hypnosis. During the war, he was a battalion surgeon and was in North Africa. And during that time, one of his jobs, along with Abraham Gardner, who some of you may remember, their job was to administer Amatol interviews to soldiers with shell shock. And they would bring these guys back from the front, start an IV, give them Amatol, and have them abreact to the horrors of what they had experienced. And one day, he was working with a soldier who was deeply repeating the trauma that he'd been through. And he noticed that the floor was completely covered in water because the IV had come out. And in fact, the guy hadn't gotten any Amatol at all. And Herb began to wonder what was going on in this person who could so return to this experience without the influence of the drug, and thus began his career as a hypnotist. He wrote later on that this was probably the least ethical thing he had ever done, in returning these men to combat. It was a time of war. Herb himself was injured during the war. He was in North Africa, and he was hit by shrapnel. He was at the tank battalion. And you hear, I can't do the story as well. He said to his medic, "Feel under my flak jacket and see if I'm wounded anywhere." He knew he was wounded in the ankle, and he wasn't. He said he had an experience of joy. How could you have an experience of joy when you have a piece of metal through your ankle? He limped the rest of his life. He said, "Of course I had an experience of joy. I wasn't dead. I wasn't going to die, and I was going home." And that also led to his investigation of hypnotizing thousands and thousands and thousands of people to establish what is the natural bell curve of hypnotizability. You're born with it. You can't increase it, but you can learn how to do it. And as Herb said, everyone is hypnotizable. I have a quote from him because he talked about quacks. And of course, hypnosis is connected to quackery and charlatanism. And he said, "Thank goodness for quacks, because they kept hypnosis alive so that we could bring it back into medicine." Herb was involved in many, many famous cases. He was involved with Sybil. He was involved with the shooting at Yeshiva University many years ago, where he hypnotized the people on the street who had witnessed the shooting to recover the license plate of the car. And he was really one of my most important mentors. And finally, about Herb, Herb lived on the Upper East Side. He had a regular table at Elaine's, and for those of you who remember Elaine's, and his table was next to Woody Allen's table. And he held court there for many, many years. I had the privilege of joining them for dinner one time. And for those of you who weren't fortunate enough to know Herb and meet Herb, Herb came 6 times a year for decades up to the consult service to train residents in CL. Herb's final day, which his widow Marcia told me about, was spent at Lenox Hill doing consults. They came home, they had a bottle of wine with dinner, and Herb did not wake up in the morning. And as I said to Marcia, God must truly love Herb for that. And so let our co-chair introduce our 2 speakers and our award winner today.
Good morning, everyone. Welcome. It's my pleasure to introduce to you the winner of the Herbert Spiegel Lecture Award this year, Milissa Kaufman, MD, PhD. She's an associate professor of psychiatry at Harvard Medical School at McLean Hospital. She is founding director of the Dissociative Disorders and Trauma Research Program and medical director for the Trauma Continuum of Care. Dr. Kaufman completed her doctoral training with Dr. Terry Keane at the National Center for PTSD. Then, after graduating from Boston University's combined MD-PhD program, she trained with Dr. James Chu with the MGH McLean Hospital Psychiatry Residency Program. She has had 25 years of experience in assessment and treatment of trauma spectrum and dissociative disorders and has published widely in these areas. Currently, she serves as primary or co-investigator on studies designed to further our understanding of the neurobiology of PTSD and dissociative identity disorder. She and her colleagues at McLean Hospital have received federal funding from the National Institute of Mental Health to study biomarkers of dissociation in traumatized individuals. Dr. Kaufman is a distinguished fellow of the International Society for the Study of Trauma and Dissociation. She currently serves as the chair of the ISSTD Scientific Committee and co-chair of the ISSTD Research and Education Fund. She has received local and national awards for her work as a clinician, as a researcher, and as an educator. She is the former Associate Training Director for the Massachusetts General Hospital McLean Hospital Adult Psychiatry Residency Program and currently serves as the Director of Trauma Psychiatry Didactics Curriculum. Dr. Lauren Lebois is a cognitive neuroscientist who is passionate about understanding how the mind, brain, and body adapt in the aftermath of trauma. As an assistant professor of psychiatry at Harvard Medical School and joint director of the Dissociative Disorders and Trauma Research Program at McLean Hospital, her research focuses on the neurobiology of dissociation and PTSD and dissociative identity disorder, funded by the National Institute of Mental Health. Dr. Lebois is the former chair of the Scientific Committee for the International Society for the Study of Trauma and Dissociation, the ISSTD, and the operations co-director of the Initiative for Integrated Trauma Research, Care, and Training at McLean Hospital. Her work has earned several international awards recognizing her significant contributions to trauma and dissociation research. Dr. Lebois is deeply committed to using her advances in neurobiology, behavior, and treatment to reduce stigma and improve care for individuals living with PTSD and dissociative identity disorder.
So it's our pleasure to present Dr. Kaufman with the 2024 Herb Spiegel Award Lecture. Dr. Kaufman. And thank you for coming.
Right. Well, thank you so much, Dr. Muskin, for extending the invitation to join you all here in New York City on this beautiful day to take part in this year's Herbert Spiegel Lecture. What a privilege it really is to honor the life and career of Dr. Spiegel, a luminary of the psychiatric profession if ever there was one. Time and time again, I've turned to his writings as well as the writings of his son, Dr. David Spiegel, for inspiration, direction, and wisdom during my own career. I really can't thank you enough for this tremendous opportunity. I'm joined today by two of my colleagues, Dr. Matthew Robinson in the center there. He leads our clinical trauma program at McLean and actually trained at Columbia. And of course, Dr. Lebois, who leads our trauma research program at McLean. Dr. Lebois and I have two goals. The first is to weave together a cohesive narrative describing several different yet interrelated types of reactions to traumatic stress. We'll create this narrative by intertwining two different languages, each derived from equally important realms: the language of clinical phenomenology on the one hand, and the language of neuroscience on the other. My job will be to present you with 3 clinical vignettes, each vignette describing the experience of a woman being treated for a specific type of trauma-related condition. One woman's symptoms were consistent with a classic type of PTSD. Another woman's symptoms were consistent with the dissociative subtype of PTSD. And lastly, one woman's symptoms were consistent with dissociative identity disorder, or DID. While each clinical vignette necessarily represents a composite portrait, and each is fully de-identified, you will hear a representation of words chosen specifically to illuminate the subjective experience of traumatic stress. Frankly, there is no better way to understand just what trauma means to a person than to listen deeply to his or her own words. Following each vignette, Dr. Lebois will then translate the language of clinical phenomenology into the language of neuroscience, and to do so, she'll present you with neuroimaging findings associated with each type of trauma-related disorder. Our second goal for this morning is to give you a glimpse into what treatment looks like for those with PTSD and DID, and to do so, I'll again provide you with some clinical vignettes, and Dr. Lebois will end things up by discussing a couple of imaging studies currently underway at McLean with some implications for treatment. So to start with our first clinical vignette, this case involves a patient I will call Barbara. Barbara was a single woman in her early 20s. She was a student at a local college and lived at home with her parents and her 3 younger siblings. When I met Barbara for the first time, she looked nervously around my office before finally choosing to sit in the chair that was furthest away from me and facing the door. Barbara reported that several months prior, she'd witnessed a violent incident involving gunfire in a restaurant near her college. She'd been out to dinner one night with friends when suddenly, out of nowhere, she described it, the whole world exploded into bullets and flying glass. She described instinctively jumping out of her chair, running away from the direction of the ear-splitting noise, and then grabbing onto a large wooden dinner table that she used as a shield. And she said to me, "Doc, I lifted that table into the air as if I'd somehow been touched by the hand of God." And this powerful physical reaction had protected her. She was not physically injured in the shooting, although several people had died. Barbara told me that after the restaurant shooting, her college had been supportive, giving her extra time for assignments and setting her up with counseling. However, as the weeks and then the months went by, she had difficulty concentrating on her schoolwork and her grades really suffered. She attributed this academic decline mostly to difficulty getting to sleep at night. She experienced vivid nightmares, replaying again and again, particularly salient, horrifying aspects of the shooting. Barbara also began to feel anxious being at school or being just about anywhere for that matter, even in her own home. She said to me, "I'm jumpy, I have 3 kid brothers. When somebody slams the door, boom, I jump. Or when somebody bounces a ball on the floor, boom, I jump. Sometimes it feels as if my heart is about to explode out of my chest," she said. At that point, I wondered aloud if it was hard for her even to be in my office. And she looked away from me for a long moment and then said, "I do not want to be here, honestly. I have to force myself to show up." I'm afraid that talking about the shooting, even just thinking about it, will make it worse. I want to forget the whole thing. But some random guy just walking into a restaurant and shooting off a gun, that could happen anytime, anywhere. I need to be ready, and I am ready for it. No more surprises for me, Doc. Never again. So let's consider Barbara's reaction to the shooting. Clinically, it was consistent with what we think of as classic PTSD, which is a very well-defined syndrome. In addition to traumatic stress exposure, diagnostic criteria include symptoms from each of 4 categories. There are intrusions of traumatic memory, accompanied by both psychological and physiological reactivity. There's avoidance of salient reminders of the traumatic event. There are negative alterations in one's mood and cognition, and there are ongoing alterations in arousal. Barbara's own words describe well many symptoms from each of these 4 categories. For example, she describes well many experiences of hyperarousal and behavioral activation. She can't sleep, and she can't concentrate. She's irritable and she's jumpy. The specific brain mechanisms associated with classic PTSD have been very well documented in neuroimaging studies for many years. So with that background from Barbara's own point of view, let's now move into the realm of neuroscience. Dr. Lebois?
Thanks, Dr. Kaufman. So historically, our understanding of the brain mechanisms underlying classic PTSD actually began with what researchers call a symptom provocation paradigms. And how these work is that researchers ask participants to come into the lab, they narrate a traumatic experience that they've had personally, it's recorded and then played back to them while they're in an MRI machine, for example. And the participants are asked to get really immersed and to a certain extent relive this traumatic experience that they've had. But what this allows the researchers to do is capture brain activity while someone is actually feeling symptomatic and they've been provoked in the symptom provocation paradigm. And in terms of the relevant neurobiology, 2 areas that researchers have focused on are the prefrontal cortex, and in particular, the ventromedial part of the prefrontal cortex and the amygdala. And these regions are involved in lots of different functions, but for our purposes today, we can kind of think of the ventromedial prefrontal cortex as an executive controller, helping us to regulate our physical and emotional reactions. to the environment. Whereas the amygdala, again, involved in many different functions, but for our purposes today, this is a region that helps to alert us very quickly to things that would be important or salient in our environment, important to pay attention to. And one example of what's very important to pay attention to are potential threats. So why are these areas so important to study? They actually have dense white matter connections, structural connections between them that facilitate bidirectional communication, so back and forth with each other. And when someone is exposed to a potential threat, there's this rapid activation of the amygdala, which helps, it communicates to other regions of the brain to help mount this full body stress response to deal with whatever potential threat is in your environment. And then importantly, in individuals without PTSD, so we're just talking about the typical threat response, the ventromedial prefrontal cortex comes online to help regulate those reactions once the threat has passed. So in other words, the ventromedial prefrontal cortex is putting the brakes on the amygdala activity, helping us regulate those physical and emotional reactions. But in classic PTSD, this is exactly what fails to occur. So the prefrontal cortex fails to deactivate the amygdala. In other words, the brakes are off, and the amygdala winds up mounting this somewhat continuous threat response, even when that threat is no longer present. And this type of brain pattern signature, if you will, is something that we see in approximately 70% of individuals with PTSD. So as Barbara's story really well illustrated, the brain pattern where the brakes are off leads to this vigilant readiness to act. These patients are activated, they're always on guard, they're kind of easily emotionally flooded. And with that, I'll turn it back to Dr. Kaufman to talk about a second type of post-traumatic adaptation.
This next case involves a patient that I'll call Angela. Angela was a single employed woman in her mid-30s, and she was referred to me by her counselor due to an inability to return to work after an assault. When I first met Angela, she appeared tentative. She had difficulty maintaining eye contact, and she told me that 6 weeks prior, a male acquaintance had followed her to her car at night after work and attacked her in the parking lot. According to her counselor, who had provided more detail, Angela had been subjected to a brutal attack involving both physical and sexual assault. After the attack, Angela had called the police, who had taken her to the emergency room, where she was treated for facial and genital wounds. The counselor said Angela had seemed emotionless, almost robotic, while undergoing physical exams and interviews. She was able to speak to hospital personnel about the attack, but her speech was slow and her descriptions really lacked detail. She was particularly vague when describing the sexual assault that had been documented on physical exam. In fact, she appeared dazed during the exam and confused about the need for a rape kit. After leaving the hospital, Angela had difficulty functioning, particularly whenever vivid flashback memories of the assault surfaced. She did not return to work, preferring mostly to stay in bed. During my interview with Angela, she described her thoughts and feelings as follows. "It's strange," she said to me. I feel like I'm some sort of zombie. I don't feel real anymore, like I'm not even in my own body. Now I just live up inside here," she said, and she pointed to the top of her head. "I know I'm having some sort of a reaction, but I can't help it. Nothing feels real to me anymore." Her thoughts then turned to the night of the attack. "I know it happened to me," she said. I remember certain things about it, but it's more like a movie or a dream, just watching it happen. I could see myself just lying there in the parking lot like a rag doll. I wasn't moving. I didn't feel anything. No pain. It's hazy," she said. "And I don't want to feel anything," she emphasized. I just know I'll go crazy if I feel anything at all. I'll lose control. I'll completely just lose control of my mind. So Angela's story is always difficult to tell, and it's difficult to hear, but we can understand it. Her reaction to traumatic stress clinically was consistent with what we think of as the dissociative subtype of PTSD. Now, diagnostically, the dissociative subtype of PTSD requires all the same criteria for classic PTSD, but in addition requires the presence of two additional symptoms. There is depersonalization, which involves a sense of detachment from one's thoughts and emotions, one's sense of self, and one's own body. And then there's derealization, which involves a sense of detachment from one's surroundings or from people or objects in the environment. Angela's own words help us to understand that during the assault, acute dissociation, a state of behavioral deactivation, may very well have protected her by distancing her, even disconnecting her from her experience, potentially making her appear non-threatening to her attacker, similar to the way an animal in the wild will freeze when approached by a predator. After the assault, Angela continued to feel detached from her body and from her surroundings whenever confronted with anything that reminded her of it. This chronic state of behavioral deactivation allowed her to compartmentalize away any sense of realness attached to the attack, but it deeply affected her ability to function day to day. Of great importance to the field are recent neuroimaging findings documenting distinct brain patterns associated with this type of reaction to traumatic stress. So let's move again from the clinical phenomenology and back into the neuroscience.
These types of studies work exactly how we talked about before, still leveraging that symptom provocation paradigm, where they have participants come into the lab, record a narrative of a traumatic experience that they've had. They play it back to them while they're in the scanner. They're asked to immerse in this memory, and then they can capture the brain activity while someone's feeling actively symptomatic. As you recall, in terms of the key neurobiology, in the typical threat response, not talking about PTSD, when someone is exposed to a major threat, you see this rapid activation in the amygdala, communicates with other regions of the brain to mount this full body stress response. And then once the threat has passed, the ventromedial prefrontal cortex comes online to help deactivate this pattern of activity. It's putting the brakes on the amygdala activity to help us regulate our physical and emotional reactions. But in the dissociative subtype, this is once again kind of exactly what breaks down. The prefrontal cortex actually keeps the brakes too tightly on the amygdala, and instead we see behavioral deactivation with those profound symptoms of dissociation. And we see this brain pattern of activity in approximately 20 to 30% of individuals with PTSD. So what we know now is that in PTSD, there are actually two distinct types of brain patterns. As Barbara's story illustrated in classic PTSD, the brain pattern is one where the brakes are off and you have this vigilant readiness to act. People are always on guard, hyper-aroused, easily emotionally flooded. Whereas in direct contrast with Angela's story, we saw in the dissociative subtype, the brain pattern where the brakes are on too tightly. You have more activity in ventromedial prefrontal cortex, less activity in areas like the amygdala. It leads to this profound detachment. These patients are deactivated, numb, separate from their own thoughts and feelings, with a sense of unreality in their body and disconnection from their surroundings. And with that, I'll turn it back to Dr. Kaufman to walk us through a final type of post-traumatic adaptation.
This case involves a woman I'll call Kathy. Kathy was 35 when I met her, a married woman, and worked as a medical professional in a large teaching hospital. 6 months prior to seeing me, Kathy's father had died. He'd raised her from an early age as a single parent following the death of her mother from a medical illness. Estranged from her father for years, Kathy nevertheless became anxious and depressed after his death. She also experienced sleep disruption due to nightmares and had difficulty concentrating at work and at home. She sought treatment, and I immediately began medication to target her sleep, as well as twice-weekly psychotherapy. I recall finding Kathy to be a soft-spoken, very highly intelligent woman. However, I also noticed that she had trouble giving a detailed account, not only of her childhood, but also of her day-to-day life. She often reported feeling foggy and disconnected. One night early on, Kathy and her husband met with me together at Kathy's request, and her husband brought up frustration, his own frustration about their recently strained physical relationship. And he wondered aloud if this was related to the sexual abuse that he was aware Kathy had gone through as a young child. As I recall it, Kathy had visibly startled at the mention of the word sexual abuse. Though clearly activated, she began to apologize to her husband for her difficulty engaging in physical intimacy, haltingly disclosing that she'd always felt strangely absent from her own body, but was afraid to think about it. Thinking about it too deeply caused her to panic, she said, and intimacy made it all the worse. Kathy also disclosed that while she didn't have very many early memories connected to her father, she did remember that he had, on occasion, acted inappropriately with her. That's how she phrased it. However, she thought that this was far overshadowed by the real harm her much older brother had endured at the hands of their often physically violent father. Her husband then asked, why did Kathy always do this? Why did she always make it seem like it was so much worse for her older brother? Especially given how guilty her brother still felt for having gone away to college, leaving then 5-year-old Kathy at home alone with her father. Kathy at this point began to blink her eyes rapidly, and her gaze appeared to swim in and out of focus for a moment, and then abruptly, she balled her hand into a tight fist and began muttering to herself in an angry tone, "Oh, she's so stupid. She's so stupid. I can't stand her." Concerned, her husband reached over to take Kathy's hand, but as she did, she jumped up, moving quickly to the other side of the room, her voice rising. "Get away from me," she yelled. "You just stay away from me. It's all her fault." Her father said with her brother gone, it would be their little secret now. She cried like a baby. "I hate her, and I hate her disgusting body." After several long moments of standoff, rather abruptly, Kathy unballed her fist, went back to her chair, and began to cry, apologizing profusely to her husband. But in doing so, she seemed extremely perplexed and deeply ashamed, saying, "I'm so sorry. I can't believe that just happened. You're going to think I'm so crazy, but that wasn't me. It felt like someone else did that. Someone else from the inside jumped out from the body somehow and said those things to you. Is that even possible? What's wrong with me? I was watching someone else say those things to you. I was watching someone else act that way, but that wasn't me. That's not me." So how should we begin to make sense of this vignette? Well, clinically, Kathy's reaction to traumatic stress was consistent with what we think of as dissociative identity disorder, or DID. And against a backdrop of a universally co-occurring chronic childhood onset PTSD syndrome with profound symptoms of depersonalization and derealization, a formal diagnosis of DID is made when 2 further symptom requirements are met. There is disruption of identity characterized by 2 or more distinct behavioral states. And there are recurrent gaps in recall or amnesia for everyday events, important personal information, and for traumatic events. Kathy's own words help us to understand that she experiences herself as chronically numb, disconnected, anxious, and highly avoidant. However, she also experiences herself in a fragmented way, as if many of her own thoughts, feelings, and memories, her own body image, and even her own behaviors are separate somehow, as if these aspects of herself are not her own, as if they belong to others, others who seem to be residing within her own mind, much to her confusion. Can this be real, she wonders. This can't really be possible, can it? What's wrong with me? As it turns out, we can, in fact, make sense of Kathy's confusion. And with that thought in mind, I'm going to turn things over once again to Dr. Lebois.
Once again, research in DID has made use of the symptom provocation paradigm in the same way that we've discussed, with one caveat that I'll walk you through here. So just like before, individuals with DID are exposed to a trauma narrative of their own while they're undergoing, for example, MRI to measure brain structure and brain activity. But the caveat being that they often ask participants with DID to listen to this narrative twice. Once when what you might call a neutral self state or behavioral state, and then again in a trauma self state or behavioral state. And these two states are prototypical states that occur in DID. In the numb or neutral state is one that feels detached, as if there's more detachment from the traumatic events, as if they didn't happen to them personally. It feels like it happened to someone else, versus the trauma or hyper-aroused self-state that feels more hyper-aroused, emotionally flooded, and has more agency and ownership over the traumatic memories, feels to them as if it happened to them personally. And behaviorally, people with DID oscillate between these different states, as we saw in Kathy's story. And they're just not well integrated. They're instead highly compartmentalized. And I'd like to point out that this is not dissimilar from how it works in PTSD. People have periods of feeling more emotionally flooded and activated, and periods of feeling more numb and detached. But again, the difference in DID is that it's more compartmentalized and has that not me feeling that Dr. Kaufman has been talking about. In terms of the neuroimaging, when people with DID are in that more neutral self state or behavioral state, their brain pattern shows increased ventromedial prefrontal cortex activity and decreased activity in regions like the amygdala, just like we saw in the dissociative subtype of PTSD. When they're experiencing that trauma self state, the brain patterns change. So this time we see decreased ventromedial prefrontal cortex activity, increased amygdala activity, just like we saw in classic PTSD. So in DID, there's a switch between these somewhat opposite types of PTSD brain patterns, depending on what self state they're experiencing. So we pull all this together. In regard to the current state of the neuroscience on PTSD and DID, we see different brain patterns leading to distinct symptom manifestations. With Barbara's story, we saw that in classic PTSD, the brain pattern is one of the brakes being off. There's this vigilant readiness to act. In direct contrast with Angela's story and the dissociative subtype PTSD, we see the opposite. The brakes are on too tightly. There's profound detachment. And in Kathy's story, in DID, there can be this vacillation between these two different signatures. I think the neuroscience can really help us make sense of each person's behavior. So there's much left for us to explore in the field of trauma spectrum disorders, especially with regards to the neurobiology. And we've started, so I think I'll just walk you through a couple of things that need to be done. We have to replicate these findings, especially in DID. We need much larger samples. A lot of the studies that have been done are in small samples. We need more of a brain network perspective on what's going on instead of focusing on individual regions. And we're also in dire need of treatment studies. So our lab has been trying to address a lot of these limitations with some of our work, and I'll briefly walk you through some of our recent findings. But first, to give you a little bit of background on brain network perspectives. So increasingly, the field of neuroscience is looking beyond how just a specific region is firing in the brain, and instead moving towards understanding how different mental processes are supported by networks of regions that are active at the same time. And if they're active at the same time, they're presumably involved in a common function, and they're thought to be functionally connected. And the jargon we use for this in the field is functional connectivity. Researchers have begun to identify different brain networks that all humans seem to have and how they support different functions. And these networks can be seen while people are at rest, and that just means we've given them no task to do in the scanner. And also when we give them a particular task to do, and depending on what that task is, it will engage more of a certain type of network versus another. So in our recent work in a cohort of women with histories of childhood trauma, all of whom had PTSD and varied levels of dissociation. So some with none at all, some with dissociative subtype, and some with dissociative identity disorder. Two networks that emerged as central to what was going on for them, the more dissociative they were the default mode network and the frontal parietal control network, also called the central executive network. So the default mode network is one that's involved in internally focused attention, self-generated thought, self-referential processing. So thinking about things related to your sense of self. The frontal parietal control network, or the central executive network, is involved in executive functioning, things like problem solving, decision making, working memory. Typically, these networks are not active at the same time. One of them is dominant compared to the other, depending on what task you're doing. But what we saw in our cohort of folks, the more dissociative they were, the more likely regions in these networks were likely to be active at the same time. And here's just our results displayed on brains. So what we're seeing is a pattern of hyperconnectivity between regions in the default mode network and frontal parietal control network, the more dissociative people were. And this suggests that this pattern of functional connectivity is a key predictor of trauma-related dissociative symptoms. And I feel particularly excited about these findings because it matches what people say about what it's like internally for them, especially the more severe their dissociative symptoms are in the case of dissociative identity disorder. So internally, it often feels like there are these kind of startling, jarring intrusions into their executive functioning. And that's exactly what we're seeing in the functional connectivity. A network involved in self-related thought is intruding into their executive functioning. So why do we care? I think an important implication of this work is that it moves us one step closer to identifying a fingerprint of dissociation in the brain that we could use to reliably identify someone with dissociative symptoms on an individual basis. And we could then track, for example, this marker during treatment to quote unquote objectively identify if someone has this capacity to dissociate. To finish up, I'm going to hand it back to Dr. Kaufman, and she's going to talk about what happened to these different clinical cases and treatment. And then we'll end with what we know about treatment and dissociation, how they interact.
I've had the pleasure of presenting parts of this talk in a number of different venues, and each time I do, invariably, an audience member will ask, what happened? What happened to Barbara, Angela, and Kathy? How did they do in treatment? Well, the patient I call Barbara did very well. And as a clinician, this did not surprise me in the least. Despite the severity of her classic PTSD symptoms, Barbara had significant interpersonal strengths, strong family and social support, and she's a fighter by nature. She had no prior history of trauma, and we easily established a strong working alliance. After a brief period of stabilization, including medication for nightmares, she began a trauma-focused phase of treatment. In this case, prolonged exposure, or PT, to target her symptoms of behavioral activation and the significant resulting avoidance. During PE, Barbara was guided gradually and in this kind of hierarchical fashion to approach rather than to avoid her trauma-related thoughts, feelings, and memories about the restaurant shooting, and to approach rather than to avoid situations or environmental cues that reminded her of the event. Over time, the use of exposure practices to process the trauma-related content, both within session and outside of session, led to desensitization and to a gradual resolution of her PTSD-related fear responding. With treatment, she began to realize the shooting was over. It was in the past. This was now, and her own memories couldn't hurt her. Her mind itself was not a danger. And Barbara did just beautifully with this modality. So it sounds like we have about 5 minutes left. And unfortunately, we have a little bit longer than that. So maybe if okay with you, I may skip ahead. Okay. I'm going to skip ahead a little bit and move on to Angela. So Angela's course of treatment was rockier. Like Barbara, Angela's life had sort of forever changed in an instant. And there was her life before the assault, there was her life after the assault, and the two lives would never be the same. Angela struggled with this knowledge. She struggled to accept it. And how does really one accept such knowledge that in one moment you're a person who's physically safe in the world, and in the next moment you're not? And as you might expect, the stabilization phase of treatment for Angela's dissociative subtype of PTSD took some time. I treated her with medication and made use of higher levels of care. And we worked hard to control her debilitating flashbacks and reflexive states of behavioral deactivation that followed. Angela was unable to go to work during this time, and indeed, at times, she struggled just to go on. However, what Angela did have, and what she had always had, was this very real and sustaining support from family and friends. And I believe more than anything, that's what allowed her to keep going on. So Angela eventually entered into the trauma-focused phase of treatment, and in this case, cognitive processing therapy. The central therapeutic goal of CPT is to gradually challenge extreme and maladaptive beliefs that form in response to trauma and get in the way of recovery. And if you'll recall, after the attack, Angela believed she might completely lose control, as she had phrased it, if she reacted to any type of feeling related to the assault she was afraid to feel. In CPT language, this belief represented what we call, what we think of as a stuck point, consisting of her inaccurate self-statement, expressing any emotion will cause me to lose control, and that results in her maladaptive behavior. She avoided emotion, and that kept her stuck in her recovery. Identifying and challenging such stuck points was an important part of Angela's treatment, and over time in CPT, she did quite well. I'm going to sort of skip once again to the last part. The good news is that Kathy did eventually recover. It just took a fair bit of time. So, Angela. So I'm going to finish up with Kathy. So Kathy developed DID as a child, and Kathy continued to have DID as an adult while functioning highly in the world. Her husband was supportive, and together they worked to raise a family. Long ago, Kathy's ability to dissociate had helped her to cope with years of unbearable early childhood abuse by psychologically displacing her overwhelming thoughts and feelings onto other aspects of herself. Other aspects of herself that as a child she personified into not me. It's too overwhelming to feel such fear. That's not me. That's someone else. It's too dangerous to feel such anger. That's not me. That's someone else. It's too real to know what is happening to my body. That's not me. That's someone else. And Kathy coped in this way, and it worked. She made it through her childhood. As an adult, Kathy continued to cope in this way, but at a cost. The fundamental problem she had is that she did not feel integrated. Instead, she felt fragmented, as if many of the thoughts, the feelings, the memories, and even the behaviors within her own experience were separate from her, as if somehow these aspects belonged to other people who seemed to be residing within her own mind, much to her confusion. As much as she tried to ignore, as much as she tried to deny this strange sense of having inside people, as she called it never went away. Within her own mind, she saw these inside people, she heard these inside people, and she even related internally to these inside people at a highly involved, kind of technicolor level that's characteristic of unusually deep absorption into autohypnotic trance. Like all people with DID, Kathy's innate and likely genetic capacity for easily entering into trance states led her to experience in a vivid way her own highly conflicted thoughts and feelings as internal interactions taking place among her different behavioral states. These discrete behavioral states, this dissociative structuring of her mind, was chronically felt as deeply perplexing. Kathy struggled with a sense of shame about her internal experience, and she strived to keep her internal struggles and confusion well hidden from others. I hesitate to, I have like probably 3 more minutes. Should I wrap it up or go ahead and finish? Okay, I apologize. So what do we know about her treatment? According to DID expert consensus guidelines that are published by the ISSTD, treatment for DID follows a phase-oriented model. Phase 1, typically involving a lengthy period of work providing psychoeducation about trauma and PTSD and dissociation, building the treatment alliance while fostering safety, stabilization, affect tolerance, and the development of a shared language. Phase 2, involving the sometimes delicate balance of conducting trauma-focused work while maintaining stability in daily life. And phase 3, involving learning how to live a new, more fully integrated life, managing stressors now without reliance on the dissociative defense. And this, of course, is a highly abbreviated description of DID treatment, but it's valuable to take into account. And what's also valuable to take into account within this phasic model is that individuals with DID may not be ready to process trauma, do intentional trauma work for many years. And why is this, you may ask? Well, the sheer strength of the dissociative defense, this not me adaptation of the mind, can be difficult to comprehend unless you consider the sheer desperation inherent in a small child longing to escape, to be a different person while growing up being harmed by someone she loves, someone she can't survive without. It's a desperate, desperate conflict. Dissociation becomes the desperate child's primary self-regulatory defense, more and more automatic over time and less a matter of conscious awareness. Behavioral states associated with an abusive caretaker become more rigid than flexible, more resistant than permeable, and more not me than me. The stabilization phase of Kathy's treatment took years. It was a slow process for her, a slow process to begin to trust me, her treater, but then really to begin to trust herself, to believe that she herself now could begin to tolerate her own thoughts, her own feelings, her own memories, her own body image and behaviors. And Kathy's DID did melt away gradually within a therapeutic atmosphere of my curiosity, firm boundaries, and a hefty dose of empathy. And over time, as transitions became between rigidly depersonalized behavioral states became more modulated, both her sense of self and her sense of embodiment became more consistent, became more her own. Was Kathy able to benefit from trauma-focused work? She was. And with it, she fully recovered, but it took quite a while to get there, and that was for good reason. I think we'll park it there.